You know how sometimes two people will take the same course and they will get very different things out of it? Well, that's true for mindfulness too. And sometimes especially mindfulness, because people are complex. Hello, and welcome to Mindfulness Voyage. My name is Ted Meissner. I'm a mindfulness teacher. And what we're talking about today is, well, a few different things. In particular, how mindfulness programs are not one size fits all. It's why we may get different things out of different programs. They're usually not designed to deal with the things that we have in our lives. But our guest today is an expert at doing some of those customizations that may be needed based on who you are in your life. Our guest today is Jackie Gardner-Nix. Jackie, thank you so much for being here. Good to see you.
Thank you. Good to see you too.
And we've had just a wonderful conversation so far, about 20 minutes before starting the recording. And I just want to thank you so much for all of that because it's just really quite heartwarming to hear all of that. But I want to start with the listeners here. Maybe you could tell them just a little bit about what brought you to mindfulness.
Oh, okay. That's going back a ways. Um, my interest has always been as a physician in relieving suffering. And a long time ago, I was a palliative physician in Canada, although I have a British accent, but I emigrated in my 30s and wanted to get into palliative care here in Canada. I'm in Toronto right now, um, as well as some family practice work. And gradually, over several years, I was beginning to be sent patients with chronic pain who were not cancer patients. And in the late 1990s, I transitioned to working with those living with chronic pain and worked in the pain clinics at the Toronto teaching hospitals, specifically Mount Sinai and then St. Michael's and Sunnybrook Health Sciences Centre later on. And I began to realize that unlike in palliative care, I wasn't able to give them a relief of suffering and restoration of ability with drugs and procedures. And one day, a patient came in who told me about mindfulness, and he had been taking mindfulness, a program, and found it very, very helpful. It was about 1999. I remember it at Mount Sinai Hospital. So I looked into it with great interest because I'd always loved doing psychotherapy groups and that sort of thing in my family practice, which I had then given up. And I was doing strictly chronic pain work. And through that, I arrived at John Kabat-Zinn's program in the US in 2001. And I have to say that I came in as a very traditional doc, trained in Britain, very skeptical. And I enrolled for that 7-day program at the Omega campus in the US. And I was really ready to just return home really fast if I thought it was too hokey. And I remember very, very skeptical the first couple of days. And somebody in the program, there were 120 in the program approximately, sat me down and said, hang in for 3 days and you'll get it. And I did. And it was transformative. And flying home on that seventh day, I remember going into the airport after having had that incredible experience, which included a couple of days of silent practice, which I'd never done in my life before, and trying to get through the check-in at the airport and get away from the crowds. And they had a meditation room. It was at Albany Airport. And, the little aircraft that I had to get back to Toronto was so tiny that there were just two pilots and like 6 or 7 seats. And they threw the peanut nuts behind them, too. So it was a bit of a worrying experience. But what I remember was that I went into the meditation room to meditate, to wait for my flight. And when I got onto that flight, even though I'd been very nervous on such a tiny aircraft on the way there, I had no nerves going back. I simply dropped into my meditation. When I got back, all colors were more vibrant. My life was more vibrant. I loved everything that I was surrounded by in my home. It was just a totally different experience. And I recognized that actually I'd seen this kind of mindfulness before in patients who were palliative because they were hanging on to their moments when they became palliative, when they knew their lives were going to come to an end soon or suspected they did. And that was too late. And I felt, we can provide this kind of experience to all my patients. The people who are living with chronic pain would likely very much benefit. So I started to refer patients to mindfulness programs in Toronto, but I couldn't find very many patients who would endure them, unfortunately, because they couldn't do the yoga. They felt somewhat misunderstood by the facilitators because they had chronic pain. They didn't feel like the other participants. And within about a year, I realized that I had to establish my own programs. Now, I was sensible enough to bring in a preceptor who'd been running programs for 2 or 3 years prior, and he worked with me for the first two programs that we provided to my existing patients in the pain clinic. And then after that, he left, and I brought on a volunteer who got trained by Kabat-Zinn, and she and I ran the programs for many, many years, later on through telemedicine. And what we saw was about 30% dropout rate, but we also saw that those who stayed and did the programs and worked them through had huge benefits. It was transformative for many, many of the patients. I never looked back after that. It was always a part of what I offered in my practice, and I actually didn't feel that the original usual care, as it were, was enough. This had to be added.
Mhm. And that's progressed since then. You've also written a book on this. I wonder if you might say a little bit about that as well.
Well, when you work with patients who live with chronic pain, cognitively, they have difficulty absorbing reading. They have what they call brain fog a lot of the time. So, full catastrophe living was a bit too much for them to take in. And over time, as we worked with full catastrophe living and originally with John Kabat-Zinn's tapes, what happened was there was an unfolding through what really were focus groups of those who were in our programs giving us feedback, especially the alumni, and we honed the program to something different than MBSR. So it became mindfulness-based chronic pain management rather than MBSR, and along with that evolved the book. And the book was just 300 pages, so it was much easier to get through. It was more customized to their needs. Um, Even since the book was written, and it was published in 2009, and John did the foreword for it. John Kabat-Zinn did the foreword. Even since then, we've continued to hone the program, and we've continued to understand that we needed to grow with the practice and grow with new understandings. And, it wasn't until maybe 2014 that we recognized that we were actually incorporating trauma-informed and trauma-sensitive work into the program. Hadn't even heard those terms before, but somebody brought those terms to us, and then, as you know, David Treleaven came along and wrote the book, and we recognized that a lot of what he was suggesting was already in our program. It had to be there because so many of our patients that had traumatic backgrounds had flashbacks during the meditations, were unable to manage the body scan until we positioned it halfway through our program. So there was a lot of shifting of the aspects of what we started with in order to meet their needs.
One of the things that I particularly like about hearing this shift in what the programs are for the communities you're serving, that is a very different kind of thing than the general person who might be attending an MBSR program, is that it recognizes everyone has a different experience. We're not all the same. We do come at this from different spaces, and that needs to be paid attention to and accommodated so people can still have mindfulness in their life if it is helpful to them. And it's not necessarily helpful the way it's done in standard programs if one is also experiencing chronic pain or has a history of trauma or various other things that may make their circumstances unique and a little harder to absorb, but we have one kind of program that may make another one very, very effective for us.
Yes, and I think it's probably through the mindfulness work because I got into it maybe 4 years after I switched from palliative care to those living with chronic pain. And I mean, this was a very needy, desperate population. I mean, I remember doing the calculation once that in a set of maybe 100 of my patients, I was the 17th physician that they had, yeah, on average, the 17th physician that they had consulted with. And I did very long narrative kind of um, histories on these patients in my charts. One of our medical students went through the charts once and found out that more than 90% of them had had trauma in childhood. And then, of course, the adverse childhood events, science research came out and showed that there was a great correlation between the events, traumatic events, but also the number of traumatic events that they'd experienced in childhood and the likelihood of developing various adult illnesses, including autoimmune disorders. And just very recently, there's been a paper that has come out which has shown that if you don't look at illnesses, but you look at chronic pain and disability, that adverse childhood events are equally correlated with the development of those. So we were clearly dealing with a population who, when they came into our programs, were going to have to meet trauma-sensitive, trauma-informed facilitators in order to benefit from the programs, to reduce the dropout rate, the attrition rate, and to really be able to stay with what we were facilitating with them. And there were a couple of things that we did. For example, Toronto teaching hospitals, their pain clinics are a catchment, they have a huge catchment area. They weren't all going to be able to come in and do in-person programs. So we were one of the first to use telemedicine. And we telemedicined this program to more than 50 communities all over Ontario, tiny little communities that had just a few people in them, but they had a health center they could go to and connect with us through telemedicine. And we did some research on that. We actually looked at pain catastrophizing, the pain scale, quality of life scales, and suffering scales, and found that when we reached them through telemedicine, we could achieve equally good outcomes for them, even compared to those who were in the room with us. It was challenging, and we learned things like the bells are far too shrill at the distant sites, and still are through the internet. And that some of our patients quailed when we did the bells. We had to learn silly things like that made a difference, that were important. And we also had to learn how to identify them at the distant sites when they were little heads on a screen. So we adopted years ago something called give us your name and your handle when you check in. So they would check in as, I am Anne, lover of gardening, or I am Tessa and I love my dog. And silly little things like that made a difference, because also my volunteers would create maps for me of how they sat around their tables, so I could actually call them by name and be pretty accurate. And that meant a great deal to them. It was so important to have that therapeutic presence with them, to be able to make them feel that I did recognize them, even if they were at a distant site. And they were very loyal. They went through a program, then they would go through it a second time and do better. And we had an alumni program where everybody going through it, say a second or third time, were all with people who'd already been through the program, so we could get deeper into discussions and deeper into inquiry. And later on, we did an emotional intelligence program as well, because they were so committed, they wanted to keep going. And so that's what we did until I neared retirement age in around 2015. And it was around 2012 that we started to train others to run this program. And we're still doing that.
And it's so fascinating to hear the same consistent kinds of things around that human interaction, recognizing someone as a person and what is important to them, as well as the fact that doing these things through a screen can be every bit as effective as in person. This is one of the hurdles that I ran into many times when teaching other mindfulness teachers about doing things online, that this can be effective. It's different, yes, absolutely. But your presence and that people are still in an environment with experiences in that, even though they might be a little different than yours, doesn't take away from their mindful presence. So I'd like to shift gears a little bit to also talk about the Mindfulness Council of Canada. And you had mentioned earlier that got started for very important reasons. I'm wondering if you'd be willing to tell that story about how it got started and why.
Yes. I recognized as I was sort of going into semi-retirement that there weren't enough people to replace for, the large classes I'd been doing through telemedicine, that we were training people to become facilitators in various parts of Canada. We were training people in the pain program. Centre for Mindfulness Studies in Toronto, we're training people in MBSR and MBCT. There's also a program over in Vancouver doing professional trainings, but it isn't enough. And so in doing a lot of speaking engagements over the years and, enthusing colleagues, they wanted to send people to our programs, but there weren't enough programs to send them to. And there was also a lack of cohesion, a lack of connectedness, a lack of collaboration across this vast nation of Canada. And so I sort of recognized an analogy with 20 years ago in palliative care, when you could have a great palliative care team in one location, but nothing between them and, many cities across the nation. So it's better now in palliative care. I wanted to create something similar for mindfulness. It was so we met, I emailed everybody I could think of that was in Canada and that I had an email for, and about 50 of us met to look at needs, the needs assessment. And that was a year and a half ago. And there was clearly a need to identify all the programs that we could identify in Canada. So that, for example, when we were finishing a program, but we wanted to stop for 9 months, we knew where to send patient referrals that were still coming in. We wanted to be able to tell our colleagues where they could find programs. We wanted to be able to tell corporations where they could find programs for their clients or for their staff. We wanted to be able to get into all the spaces, so not just clinical, but also corporate. Education was hugely important, correctional, parliamentary, and so on, because the UK is way ahead of us in their parliament in having brought mindfulness in. And the national health system there has also incorporated mindfulness. It was very spotty a few years ago, but it's better now. So we wanted to follow suit. We wanted to know where we could send people, where we could send colleagues to look for programs. Also, if you're a program where a corporation approaches you and they want your program, you need more people to teach it. So how could they find more qualified people that they could then teach their specific aspect to fairly quickly and expand into that corporation that was asking? So this was where we wanted to go. We started Mindfulness Council of Canada. We have 6 wonderful board members. We have 3 wonderful board advisors. One of our board members is Indigenous. We wanted to ensure that we threw a network out across Canada so that we could connect with each other, collaborate with each other, provide a website where anyone could go to find a program. And now there's so much more access because we can be on the internet. We can do this remotely with our platforms like Zoom. Although, having said that, I can't really cross provincial boundaries unless a college say, now I know BC and Alberta will let me actually cross provincial boundaries because they don't have some of the programs we have in Ontario. So I can teach across these provincial boundaries, but I have to check with every college of each province and territory. Some of the social workers can do that too. And we are poly-scholared, which is fantastic because we have many disciplines that can be taught to teach mindfulness. And so we have literally started 9 months ago. We have our website, we have some donations, we want to go for grants. Um, we want to provide people sometimes with the funding to talk at conferences about what they're doing. We want to provide some of the participants who can't afford a program that's not covered by the health system and allow them to take a program, so some grants for that as well. But we want to collaborate. We're putting on all sorts of sessions where we are providing information. We did a session in February, which was about integration of mindfulness into the education system, and we had 3 great panelists speaking to that. And the next session will be the integration into clinical practice. We have 4 panelists from each side of the nation who are going to speak to that. We're going to showcase programs as well, run showcase series. And we're also obviously going to do integration into corporations and business as well. So, and I've met so many more people doing this. It's been absolutely wonderful as we've thrown our net out. We've been collaborating, and when we were preparing the panel for the education session, the emails going back and forth between people that have never met before was just breathtaking. We've really started to network and to collaborate, and it will grow from here. So that's what we're doing. And we'll also have the big discussion about standards, because we do want to establish standards, but we don't want to be exclusionary. We don't want to exclude those who haven't quite done the classic MBSR, but are doing great work with mindfulness strategies that follow all the appropriate guidelines. For example, there's guidelines that have been put out by University of Bangor, by Crane's group, about what should be within mindfulness programs that would create that a sense of security that it's still a mindfulness program. So we want to be non-exclusionary, but we want people to be well-trained facilitators with established personal practices and good embodiment. We also want to honor the fact that Canada contains so many cultures, and many of the immigrants into Canada and those who are second generation, etc., have come from cultures where this was inherent and may not have been called mindfulness. And we want to honor that. And also the fact that the indigenous populations, that those of us who've immigrated have, have joined and are occupying the land that they nurtured, that culture, the many nations within the indigenous populations were already very mindful in the way they approached their land and their appreciation for what they had. So it's important for us to incorporate all of that and not think that we know best.
There's so many aspects to what you're sharing about what the organization is doing. In particular, things that are standing out is your use of collaboration, because one of the challenges that I see in the mindfulness field in general right now is a mindless reactivity towards competitiveness in how we present, and how can you outmarket the other guy, instead of not just cooperation but collaboration. So it's wonderful to see that, a respect for indigenous cultures, and not just a respect for over there, but an active participation. You have leadership inclusion in this, which is of course one of the hallmarks of an authentic engagement with that. And then also holding on the standards, whether it's things like the MBI TAC or the IMI network or BAMBA or whatever it happens to be, recognizing that this is a complex discipline. And there are aspects to it that, for the health of the general public who are not experts in this, being able to rely on us to help provide that and keep those boundaries going. And I'm so glad you mentioned that upcoming session on April 24th, at least as of this recording, and I'll try to get this published before that, on that integration is just such a wonderful and fascinating thing. I'm hoping to get to participate in that as well, because it's within my field. So thank you for all of that. And one of the other things I wanted to ask you about was in our discussion before we started recording today, was on mindfulness with veterans and those who are experiencing trauma. I wonder if you could say a bit about that for the listeners here
Yes.
as well.
Yes, indeed. So we established the mindfulness-based chronic pain management program, as you know, but that was for generic chronic pain. So people come into that with all sorts of conditions that they're living with chronic pain. And we know that veterans have a very high likelihood of developing chronic pain. So it wasn't much of a stretch to recognize that it would be nice to have a program that was more customized towards their needs. We'd had veterans within our programs throughout the years, and many of them had really resonated with what we were offering and had suggested that it would be a great thing to offer to veterans, as a homogeneous group, um, veterans who were dealing with chronic pain, and most of them would be dealing with post-traumatic stress disorder as well. So a couple of years ago, we did have a veteran come through our certificate program training to facilitate, and he was looking to co-facilitate, and he did at least 6 years, and he worked with another physician in the general programs for chronic pain, and that physician retired, and I was sort of semi-retiring. What I mean by that was I wasn't really retired. I was going to leave my clinic work, but I was going to now play in the sandpit a bit with things like customizing, and doing a bit more work, and of course evolving the Mindfulness Council of Canada. So I joined with the veteran to co-facilitate a couple of courses that were specifically aimed at veterans. Now, let's bear in mind that the majority of people that enroll in our mindfulness courses for chronic pain, the majority are women, and so a lot of our languaging was around what would appeal to women, those who identify as female anyway. And so we needed to change how we approached providing the mindfulness training for veterans, and we learned a lot. And what we've now decided to do, we've just gone after a grant to do proper focus groups with veterans, and then to launch a couple of programs with co-facilitators who are veterans with lived experience. One will be a program I will run in English, and another will be by a colleague who will run it in French in Quebec. And we have a scientist working with us. And we will do our best to evolve a program that appeals better to veterans, and learn from them. So that was one of the customizations. And we actually had another customization we did as well that's dear to my heart, which is a program we've evolved for those living with migraine and post-traumatic headache. And the co-facilitators are myself and a migraine coach who's done our certificate. We both suffer from migraine disorder, and that's proving extremely relevant. We've worked with groups online, so they're all in their own homes, about 18 to 19 participants. And we're very heartened by the customization because they have given us feedback that they've been trapped in their homes with chronic migraine, and some of them have been able to transform and get out and do more. And so customization seems to be important, and using facilitators who are connected to them, who our lived experience seems to be very important as well. These are directions I think are very well worth exploring.
Absolutely, because of that connectivity piece that enhances the kinds of trainings that we're doing within mindfulness programs, whether they're customized ones or vanilla MBSR or MBCT, whatever it happens to be.
Yes.
So as we finish up today, wondering if you have any other insights to share with listeners, maybe website addresses, things like that.
Yes. So, we just did a presentation. We do it once a year to a large cohort of students at University of Toronto. They do their pain week, and three of us present a workshop for them on mindfulness and how it's so effective for chronic pain. One of us is a physiotherapist, one is an occupational therapist, and I'm a physician. So poly-scholared, and we show them what can be achieved. And this group, we had 500 at this recent workshop. This group was medical students, medical physician assistants, occupational therapists, social workers, dentists, and so on. It's what's amazing about mindfulness, I think, is that it can be taught by so many different disciplines. But that said, we've also recognized that we are really providing a form of psychotherapy when we're working with those in a clinical environment. And that in each jurisdiction, there are rules about who can provide psychotherapy, such as in Ontario, there are 6 professions that can provide psychotherapy. And that includes nurses, MDs, registered psychotherapists, psychologists, occupational therapists, and social workers. So people do need to make sure that they're within their scope of practice when they provide mindfulness. And that needs to be, I think, amplified. MBSR is not considered to be one of those, but certainly MBCT is, which is mindfulness-based cognitive therapy, and mindfulness-based chronic pain management, and there are a few others as well. So to be aware of that, I think, is important. To be aware that mindfulness is not a benign intervention, that it can really bring up insights into things that have been buried in the mind, that have been in the dark recesses of the mind. These things can come to the surface, and you need to be a well-trained facilitator to contain the space for those people, but it's wonderfully rewarding if you can do so. I think that's extremely important, to contain the space well. And the other thing that struck me is that the new work in the psychedelic field, psychedelics are coming on the map now in clinical practice for depression, for pain, for all sorts of conditions. I think that mindfulness is the slower boat to that. And I think that the psychedelic practices are the fast track, but I think they're doing something very similar. And we've heard back that those who've been trained in mindfulness as clients and patients they do find that very rewarding when they step into doing the psychedelic work. It seems to be better for them if they've had the original training in mindfulness before they step into that. But I do think that it's the faster route for some people who have been desperate and have been extremely affected in ways that were not helped by other interventions. So those are some of the things I would want to mention.
This just came up, the psychedelics, in a conversation yesterday, and I'm planning some episodes on that coming up because that field has had a very difficult time kind of recovering from the 60s and how things were done then, and not quite with the same kind of clinical oversight that we might have today. And so it's gotten a bad rap. And now I see that opening up a little bit more. So thank you for bringing that up. I'm going to have links for those who are watching, where links are found, wherever you're watching this on. So our guest today, Jackie Gardner-Nix, thank you so much for being here. Really enjoyed our conversation, and I'm looking forward to speaking with you again about how things continue to unfold in Canada.
Thank you so much, Ted. Thank you for shedding the spotlight on Canada and mindfulness. I really appreciate that.
Thank you for being here and for watching. I really appreciate you spending a little bit of time with us. And hopefully you'll subscribe and maybe help by sharing this podcast with others. That's really what this is about, helping others to find out how mindfulness may be making a difference in your life. So remember, until next time, every moment you have a choice. Make it the best you can. See you next time.